Thank you, Dr. Sizemore. Thank you. And Dr. Thompson, it's a pleasure to be here and to be a part of this event and this very important conversation. And I will be doing less of the talking and just moderating because we have a lot to get to in this next hour, and we do want to make this as engaging as possible for you. So please feel free. There will be a time when you'll get a prompt to submit your questions, and I have a nice large monitor. Thank you very much for the size of the monitor. I hope the font that the questions come in on are as equally as large so I can make those out, and then we will integrate those throughout our conversation today. So feel free to chime in as a question comes to you, and we hope we can get around to it. I'm pleased to have this distinguished panel of lawmakers. This is going to feel like a Kentucky Tonight, actually, on Monday night, but not as much. It will be a little softer today, I think. I'll start with Senator Stephen Meredith, chair of the Senate Health Services Committee. Representative James Tipton, chair of the House Education Committee. Senator Jay Williams, Vice Chair of the Senate Education Committee, and State Representative Kim Moser, Chair of the House Health Services Committee. You've heard a lot of chatter this morning about some legislation and some policy decisions that have helped address these critical healthcare shortage needs and areas. And the General Assembly has also stepped in recent months to do that. In 2022, there was the establishment of an workforce innovation fund and program to help develop a workforce to meet the needs of today and tomorrow. So we want to start talking about all of this, and I'll start with you, Representative Moser, because you, of course, have a history in this in more ways than one, not just as a policymaker, but also as in the nursing or in the healthcare industry. Talk to us about the way you have approached evaluating the needs, the healthcare needs of Kentucky. Senate President Robert Stivers shared with us during lunch about the aging population that we are, and ever-increasing healthcare demands are going to be put on the system to meet those aging population needs.
Right. Well,
oh, and please turn on I don't think your microphones are already turned on, so yes, please engage.
Okay. I think I'm on.
Okay.
Thanks, Renee. Thank you all for having me today. We do a lot of analysis of the data that we have available to us when we're looking at making policy decisions. And we I think, knew that we had a healthcare worker shortage prior to COVID, but certainly it was highlighted during COVID. And I think it was really, it became glaringly obvious that even though we had hospital beds, we didn't have the staff to man those beds. And so I think just in watching the data, hearing from all of our experts, we work closely with the Hospital Association when we're looking at hospital-specific employment and staffing. We work with the Kentucky Medical Association and the Kentucky Board of Nursing when we're looking at those professions in our state. And then we have Primary Care Association. We have a lot of groups who are working on healthcare largely and broadly. But when it comes to the healthcare worker situation, those are the folks that we rely on. So it's not anecdotal. We do hear a lot of anecdotal evidence when it comes to healthcare, but it's really important that we rely on actual data.
And we know, I think, from what I remember, it's more than 16,000 nursing shortage by the year 2025, and that is ever closer, right? We were nearing the end of the fourth quarter of 2023. That's looming large.
Mm-hmm. It is, and that's a potential big problem. And so it's important that we continue our work to create pipelines in various ways. We've done that with our community health worker bill that we passed a couple of years ago, 2 sessions ago, I guess, I lose track. But ensuring that individuals, for example, who are certified as community health workers and are coming into the healthcare worker pipeline, that they're also given college credit through KCTCS. when they're being certified. So it's making sure that we are thinking more broadly about how to establish that pipeline. So that's just one example where we are. I just saw an article, I think it was yesterday or this morning, about U of L's new program to enhance primary care and to get more new med school graduates into primary care. And so expanding some of the programs, I think the Trevor Clinic and some of the programs down in West Kentucky where they have an established residency to ensure that for the folks who are interested in primary care and practicing in primary care, that they have slots. And I mean, I can keep going. I've got lots of information about graduate medical education, but
right.
Yeah.
Well, we do know that the average age of a nurse is 50, and I want to go to Senator Meredith now, Mr. Chairman, and we know that, we know that there are only 4% of people of color who are in the nursing industry. We know that there's a lot of attrition happening in the nursing industry for lots of reasons. And so when you think about, as someone who is a former hospital executive, and you think about what's facing not just the nursing industry, but overall providers in other areas and specialists, what do you think, can you point to in this past session of 2023 or 2022 that you can say really help try to shore up where we are now with these workforce challenges?
Well, thank you for the question. And I assume when you mentioned about the aging workforce 55, that question came to me because I think I'm the oldest one on this panel. And I assume, but
that was totally unintentional and coincidental.
I'm sure it was. And this is an issue that I've described as it's been there for years. We saw it coming. It's like watching a train wreck in slow motion. And COVID didn't cause it, but it kind of pushed it over the cliff. And I think we're racing to catch up. We passed some very good bills this last time to fund some new initiatives in my district in particular, $38 million, I believe it was, to Owensboro Health System to create a healthcare innovation system for that part of the state, which is greatly needed. Representative Ken Fleming's bill, House Bill 200, which is a public-private partnership to help fund tuition for healthcare providers, which is also great. I'm concerned, though, we haven't done enough. And while this problem we know exists, I think it's going to be more pronounced in rural communities. And what has really added to the burden of it is the inflationary pressures right now. COVID, as I said, kind of pushed off the cliff. We're trying to adjust for it. But now we have to deal with inflation in increases in salaries, which is going to make it more and more difficult for rural healthcare providers to be competitive. I've said from the very beginning, I think it'll take at least a decade to address this problem, but I think we're going to have to take some more immediate measures, and not just with funding for getting people in the pipeline, but looking at the work environment for all healthcare providers. It's in a tremendously stressful situation, and I don't think we've done enough to recognize that. Historically, I think we've looked at ourselves as any other industry, and we've got to think outside the box and really look at the whole person rather than just an employee. I saw some recent statistics regarding physicians, the number that are leaving, and their biggest stressor right now is the bureaucracy that's around it. And that's another issue that we're going to have to address, not just because of workforce shortage, but the cost of health care in America. As you and I talked previously, this is a crisis that is really on the horizon. It's getting to be the perfect storm. Right now, we're spending close to 30 cents of every dollar just on administration of health care. So that means a lot of the time spent by healthcare providers is just doing the so-called paperwork associated with healthcare. And it's stressful, will not allow people to do their jobs. And if we can address that, there's a twofold benefit to it. One, it gets people back at the bedside, so to speak, but also I think increases healthcare providers' satisfaction with their professions and makes for a much more productive system. But it's going to be a challenge to get there, and I don't think we've done enough yet. This next legislative session is going to be particularly challenging. I'm glad I'm not on appropriation of revenue this time, but we're going to have to make some very difficult decisions, particularly because of the inflation situation that's before us. But I'm confident, and I haven't had any conversation with our leadership about this, but I'm confident that we'll have to make a dedicated effort to increase funding for education, workforce development to address these very issues. but it is a crisis that's here and now, and we're going to have to give it some immediate attention.
Right, one of the things you mentioned about the bureaucracy, that some of that's tied to the federal government, correct? So there's only so much perhaps that the Kentucky General Assembly can do?
There is, but specific to our Medicaid program, and I know for me and my legislative colleagues, it's going to sound like a broken record, but we have 6 managed care organizations that administer our Medicaid program, 6, and the federal government requires 2. Tennessee, who recently was here to testify, they have 1.7 million Medicaid population as well. They only have 3, and I have filed legislation for the last 4 years asking for us just to have 3. Because think about it again, you've got 6 set of rules for healthcare providers that they're all different, they're all unique, they're all distinct. It's impossible to keep up with, and it places a disproportionate burden on small providers and rural providers, and we have to change this trajectory. Right now we're spending 18% of our gross national product on healthcare, and with an aging population, if this thing ever hits 20%, it could virtually collapse our economy. That's what happened to Russia during the Reagan administration. We got in a spending war on the military, and they were spending over 20%, and that's what caused the Soviet Union to collapse. This is a real risk to our economy here in America. And think about it from an international market standpoint. We can't be competitive when our healthcare costs are double what other industrialized nations are. Right now, we're spending about $13,000 per capita on healthcare. The next closest nation is Germany, and they're at $7,000. So you see that pricing disparity, and that's reflected in our pricing of products internationally. We can't be competitive. We've got to wrap our arms around this. So doing things like, particularly our Medicaid program, where again 1.7 million of our population in Kentucky are on Medicaid. If we can reduce that administrative burden, which I think is probably well in excess of 30%, we can make a better work environment for our healthcare workers, but also free up funds to expand healthcare. It's great that we have these programs that expand insurance coverage for our residents, but if you really don't have access to care, access to a doctor or nurse practitioner, it doesn't do you much good. And the most startling statistic to me is in Kentucky, 40% of our population is rural, but only 17% of our primary care physicians are in rural Kentucky. That's not a recipe for success, and we have to address that, and we need to do that immediately. So I'll be filing that bill again, and I hope it gets more traction this time, but it's imperative. It's not just a wish list. I think particularly for rural communities, rural providers, it's an absolute must. But again, particularly for our healthcare workers, spending your time at a computer terminal and trying to get pre-authorizations approved, that's not what they train for. And that's why they're wanting to leave the profession, because they're just not getting the value out of it that they used to. I think everyone who gets into healthcare does so for very altruistic reasons. We want to help people. But when you can't see that on a day-to-day basis, you step away from it. Plus, we're still predominantly a family-oriented industry. The child care situation has added to this as well, and that's another crisis we're going to have to address during this next session that I'm not sure what the solutions are to, but we have to do that. But that's what I mean in terms of looking at the total person. It's not just your work life, it's your family life that we have to make sure we're giving people a quality family life, and that's a struggle for everybody who's in healthcare right now.
Senator Williams, good to see you, sir. So let's kind of pivot and make some correlations between education, K through 12, and where we are with helping a talent pipeline for healthcare professionals. We know we talked about House Bill 200, which is that public-private partnership, and folks have heard a lot about that heretofore. But what do you think, as Vice Chair of Education, what's the next step and the next level of appropriation? Looking at $3.7 billion on hand. When you go into 2024, January 2nd. Should some of that money be redirected or directed for healthcare workforce creation?
Well, I think one of the things that the General Assembly is very interested in is this on? Yeah, one of the things is the workforce development piece of this, and workforce development in K through 12 education. We're seeing a lot more dual credit enrollment, and it's not just shortening the pipeline, but starting the pipeline earlier. A lot of the kids that are very excited and 11th and 12th grade, they're coming out. It's just a long path. But if we can get them dual credit, if we can get these instructors at the community college or the college level fully certified for 11th and 12th, they can do one thing. It can solve our teacher shortage and push the certified teachers down lower and get them into the workforce faster with a real credited career, so they don't have to go 4 years and then 2 or whatever they're doing. They can get those 2 years, shorten the cost, shorten the learning curve, get them out in the workforce a lot sooner. Not everybody will go through the whole curve, but they will start out a lot earlier. And that's what we got to do. We've got to fast track these workers. I mean, a lot of the plans and the programs are coming along, but as you say, it's a pipeline. So shortening the pipeline and then starting the pipeline earlier for our kids, I think is one of the emphasis. One of the other things, personally, for me, is I have Kentucky State University in my district. Since 2018, I believe they've been asking for a science center, which will probably be used for nursing. This year, they have 200 nursing centers coming into a health science center that is just antiquated. And so they're asking for $50 million, and I sure hope a part of that goes to the $50 million. You talked earlier about the number of minorities in here. This is going to go a long way to engage a community into our healthcare system. So I'm hoping that we will, and I think we will have the support for that health science center and 200 new, just brand new freshmen that are going to be in the pipeline for healthcare and sort of approve some of our numbers later on. But I think the key is pushing it earlier and shortening the pipeline.
So to Chairman Tipton, you know this issue very well, and education, of course, is the thing that you are most concerned about. So when we hear where we are with healthcare workforce, and we know that there are workforce issues across industries and cross sectors, but when we deal with this specifically, we do know that there's already good work going on with career pathway programs in our high schools, et cetera. But how soon should this be trickling down? Elementary, we see some activity in middle school. What will you advocate for?
Well, Renee, first, thank you all for the opportunity to be here today. This is a very critical issue. I think about it every time I look in the mirror in the morning. I'm a baby boomer. I want good quality workforce in the years to come, healthcare workforce in the years to come. But I think we have to expose children younger, maybe not necessarily direct them, but to expose them in the upper elementary and the middle school age to what possibilities there are out there. Senator Williams referred to the dual credit scholarship. We made some changes in the last budget language. We increased the number of dual credit scholarships a student is paid for a student from 10 to 12, trying to strengthen that. There's right now a lottery fund, trust fund task force that's meeting to evaluate how we use those lottery dollars. We're talking about, we always talk about the negative, but we've got roughly $350 million of lottery funds that are helping students pay for post-secondary education across our state, and that's vital. So we have to continue to expose them, but one of the things that we haven't talked about, it's one thing to have the students, but the students need to be prepared. And we have many challenges. Senator Chair West and I have worked for many years, and in 2022 we passed Senate Bill 9, the Read to Succeed Act, and that's focusing on early literacy in K through 3. Right now, I'm working on legislation for a numeracy act to focus on our numeracy skills. In order for us to have that pipeline, we have to have students who are prepared and capable to do these tasks. So, we're focused on the short term, but we also have to look at the long term going forward. So I think those are some of the things that we have to focus on, helping to better prepare. I kind of envision this, President Thompson, we've kind of talked, it's kind of like an interstate highway. A student, maybe in high school, through dual credit, to get a C and A, they can get engaged in the workforce. Later on, they may decide to take an exit ramp, maybe become an LPN, go back to increase their wages, they can continue on. So we've got this system, and we're going to see more and more adults. We have to consider the adults as part of the the performance funding task force this summer, work group, and one of the things we're going to recommend is adding an adult metric to performance-based funding for higher education, because we've got a lot of adults that are going to be out of a job in a few years because of technology. Their jobs are no longer going to exist. They're going to have to be retrained, reskilled. So those are some of the things we've got to focus on.
Thank you for saying that. And just to do a shameless plug, Chairman Tipton was part of a program we did some weeks back about early literacy, and that is available online at ket.org. It was a very good discussion hosted by our very talented Kelsey Starks. I want to get to, you mentioned adult learner population, but we also know there are other underrepresented groups like low income. We mentioned people of color, immigrant and veteran populations. Any consideration given, and this is for both you and Chairman Moser, about how you engage those populations that are previously untapped for healthcare fields?
Yeah, I have a few things that I can talk about, and you can get the sense that there are a lot of things happening concurrently. You know, we're each thinking of different pieces of this puzzle, and it's a pretty daunting task. But when you were talking about engaging students early, there are programs going on in our state. I don't know if you are familiar with Game Changers and Christopher 2X and his Future Healers, and that's part of exposing kids who may not ever have an opportunity to really see outside of their neighborhood. And it really started as a violence prevention program, but it's kind of morphing into this exposing kids to healthcare in Future Healers. That's one. AHEC is another program that we have, the Area Health Education Council. Am I getting that wrong? Thank you. Who engage kids in junior high and high school in a health career field. And we are, I just had a conversation right before I came up here with our friends from AHEC about a program that they're working on in Eastern Kentucky to bring more nursing students into training programs. So we have, those are two programs that we can highlight. To Senator Meredith's point about the issue of burnout and how do we retain our healthcare workers. I mean, I know I'm kind of jumping around, but we have some ideas about how to mitigate some of those issues. I have, this will be year number 3 that I file eliminating or providing a waiver for prior authorization. And that is a huge barrier for our healthcare workers. They have to hire entire staffs to deal with having prior authorization getting approval just to be able to provide health care to the patients that they know that the patients need. So, that would be eliminating another layer of bureaucracy. And we see well-intended measures that become real bureaucratic nightmares and administrative burdens for our healthcare workers and our healthcare system. EHR is one of those well-intended programs having electronic health records, and the idea is that there is a level of interoperability between hospitals, and it makes it easier for patients to, when they travel or change doctors, that their records follow them. Well, someone has to input all of that information, and I've been married to my husband for 38 years. We got married during first year of medical school. My father was a family practice physician, and my father-in-law was an internist, so I've seen kind of generations of changes in the healthcare system. And I can tell you now, my husband is 61. He leaves the house at about 5 a.m. He sees 50 to 60 patients a day, and then he comes home and he charts for 3 to 4 hours every night. And this is new. This is new within the last 10 years. And so this is what is burning our healthcare workforce out. he's trying to figure out how to retire. I mean, it's too bad, because he is a very conscientious example of what we want in a physician and a healthcare worker. And if we can't retain our healthcare workers, and it's not just physicians, I mean, nurses are asked to do more and more. We have increased our nursing scope of practice to fill in for a lack of primary care. So, I mean, we're helping and we're hurting the situation all at the same time. So, I mean, these are the things that keep me up at night, and that drive me to work on our healthcare worker issue.
And so can there be anything done by state lawmakers to address some of this laborious bureaucracy and red tape and paperwork that your husband is doing 3 to 4 hours after working a 12, 15-hour shift?
Well, I mean, the prior authorization is a big piece of that. And, another piece of it is we really have no liability protections for our healthcare workforce in Kentucky. And we would need a constitutional amendment, and it would be very, very hard to overcome. I think that if we could put some liability protection, some tort reform in place, it's an uphill battle, because our good friends attorneys are, and rightly so. We want to make sure that patients are protected from anything untoward or anything bad that happens, but at the same time, we're driving up the cost of health care by creating this or allowing this litigious system to remain in place. And so, I mean, that's a big burden. And when you go to work and you think about how to cover yourself by charting and ordering tests that the patient probably doesn't really need, but it's covering yourself or the hospital or your system to keep from getting sued, that's not helpful. And so, maybe that's something that, the European systems have that we don't have, that keep the costs down. There are a lot of things that are going on, and those are a few. Workplace violence is another one.
Mm-hmm. Interesting. I was just going to say the Kentucky Chamber may have that as part of their public policy platform for 2024. Tort reform, which we've talked about many, many years. We've had experience with medical review panels back in the days when State Senator Ralph Alvarado was a part of the General Assembly. Those things don't seem to move very far, and if they do, they get hung up in court. So tort reform is easier to say than it is to achieve.
Yes.
And there's a lot of concern that does interfere with patient care. So that's probably another conversation for another day, but we can all go down these roads.
It's a long conversation.
It's a long conversation. I do want to make a couple of points about how higher education enrollment, as Dr. Sizemore and Dr. Thompson shared with me, is down, but in healthcare, their fields, there's an uptick in enrollment. So if there's an uptick in enrollment, there's an interest in pursuing those careers. But what are we doing to help those kids, students of all ages, be more successful? Are there wraparound services that address issues of dealing with your mental health and the things that you will experience on the job and helping you understand what you will be facing? Is that available, and what can the General Assembly do to encourage that to be available?
Renee, I'm glad you brought that up. It amazes me the rise in the instance of mental health. I'm serving on the school safety task force this summer. And in our last meeting, we had mental health specialists come in, and we're seeing that. And it's not just in school, it's just in life. Life is stressful. And helping people how to address mental health. And one of the things that we talked about in that meeting, and I think is important, is what I'll refer to as Tier 1 mental health. Before you get to a problem and have to do interventions, what can we do to improve quality of life? What can we do to help people understand how to deal with stress and improve their mental wellness? So I think that's essential. I know that we have part of the issue we have with things like mental health and things like even with students who are interested in healthcare is we have to have teachers. And I've been told that it's a challenge to find people who are qualified to teach, say, these nursing courses and things like that. So we've got a lot of challenges we have to work on, continue to improve. And getting back to your earlier question, you'd asked about minorities and low income, how we can engage them. One thing, a bright spot, just in degrees in total, since we started performance-based funding in 2017, as President I keep referring to him, he's sitting right here, as Aaron has told us, we've seen an increase in the number of degrees being obtained by underrepresented minority. But when we examined that formula, we did have a weakness, and that was in our low-income students. So another one of our recommendations to the General Assembly is to increase the weight for our low-income students. And a lot of times, you mentioned wraparound services. If a student's taking classes, they're trying to live, they're working, and their alternator goes out, and they don't have the money to replace that alternator, they can't get to class. Or if they can't find child care. And it amazes me, I recently talked to a student from the University of Louisville, their student government is hunger, food insecurity on our campuses. We have a lot of issues that we have facing us, and I think we have to address this holistically. And we have to think of our students just as not as completing this class or completing that class, but helping them to become a complete person and help them holistically.
To your child care point, the General Assembly did pass the Child Care Assistance Program, $15 million made available, but we understand that people aren't either aware of it, it's not being tapped to its optimal capacity. So along with having great programs and great policies, people got to know they're out there. They got to know what community health workers do. They have to understand how they can help facilitate health care. What can you do from a policy? I'll go to this side now since I've picked on this side enough. What can come from a policy perspective to help, I hate to use the word, market this better?
Well, first let me confess that I'm an unabashed rural health care advocate. I think my colleagues know that. And back to the issue about minorities in disadvantaged populations, and you see it in urban areas and rural areas. And one of the problems is the lack of resources to address those things. And one of the bills I passed last session, Senate Joint Resolution 54, asked the Department of Medicaid to develop a payment methodology based on the National Deprivation Index. This is calculated by the national government on a per zip code basis and redirects resources to the most disadvantaged communities. And that allows us to reach out to these people. We've never been able to do that before. Now, I assume that's going to kind of be like zero-based budgeting. What we take from one group, we have to take away from somebody else. But that's not necessarily bad. If we lift up our most disadvantaged, then they become vital parts of our economy in the future, and we just continue to ignore that, and we can't continue to do it. Things such as health care, it's not the same for everyone. Same with child care, it's not the same for everyone. The challenges are so unique in our rural areas and for our urban deserts that we have that we have to address that. And I've asked the question time and time again of several people, why would anybody choose to practice medicine in one of these areas knowing you're going to make 25 to 30% less than your urban counterparts? It's a fair question. And folks can never give me an answer, and it's just not right. I'm a big proponent of John Nash's theory on economic equilibrium, and without going into that in great detail, it simply says you engage in symbiotic relationships, win-win. In my contention, if we can invest in rural communities, in our urban areas that are most disadvantaged, by investing in those areas is our greatest rate of return. We deal with tax policy that we've struggled with for years. Our biggest challenge is that 50% of our income has been exempted for taxation over the years. Then you got 40% of your working age adults are not in the labor pool. That leaves a very small percentage of our population left to carry the tax burden for this state. And who is it? It's our working families. So that's one of the reasons we push for consumption-based tax, broad-based consumption-based tax. I think that's going to help address a lot of these issues. So people who've never paid taxes before now have to pay taxes. We're not interested in raising people's taxes, but we want a fair tax system when we presently is not. And that 40% that's not in the workforce, if we can get them trained and in the workforce, there's two benefits to it. One, we reduce reliance on entitlement payments, so there's a savings that we can shift to someplace else. But also they become taxpayers themselves. And that's the quickest way to lift Kentucky out of poverty. and we have to do that. But we've got to commit the resources to it. Of all the things we're going to talk about today, certainly education's got to have a firm commitment for funding, but so does child care. And the numbers that I'm hearing from folks are truly alarming. You threw out $15 million. I talked to a group last week, and their ask was $330 million. And this will be my fourth budget session. I think it's going to be the most challenging one that I've seen in my time in the Senate, because we've had so many groups that are reliant on COVID funding for operations, and now they're coming to us to say, you have to pick this up. Coupled with inflation, it's going to be challenging. That's why I say again, Dr. Thompson, I think we got to make some priorities, and it's going to have to be education, workforce development. If we don't fill these jobs that we're creating, then we haven't gained anything. So it's a multifaceted problem that doesn't have any easy solutions, but there's got to be start someplace. And again, for healthcare specific, I want to see payment parity for urban and rural areas, and I think it'll benefit everyone in the long run. It raises the tide for everyone. So that's a long answer to your question, but it's...
While Senator Williams prepares to chime in here, I'll ask Heather if you want to bring in any questions that have come in on the board. Oh, wow. Yes. Okay. Senator Williams, do you have anything you'd like to add at this particular point, or shall I just go to the questions?
Tell you what, let me take the first question.
Okay, so the first question is, has there been discussion about asking healthcare workers what Kentucky could do better for them?
So I just came back this time. There's some discussion. I think there's a great need to work with healthcare workers later on. One of the things that I've seen my wife's family practice doc, we have a different workforce today, and because of sort of the structure of how healthcare is very regulated and run, we have a last generation working environment. And our new workforce develops different things. They may, my sons and I'm a technology guy, so I'm going to say the answer to this is technology. My son has a technology company. He hires gamers who sit out in a rural area and work 6 out of 8 days and get every other Friday off. That's the way they work, and he hires them. My wife's family practice doc was required to do exactly what Dr. Moser had to do, work all day, come home and code all night, and she had a young family. And she finally had to step out of the system. I know another nurse who was told, no, you can't work 20 hours. You got to work full time, and that was her only option in the area. So these are things where I think we need to accommodate how this next generation, how actually some of our generation might like to work these days. So we're talking about reintroducing the older generation in the workforce. They don't want to come back full time, but a lot of them have a lot to contribute on a part-time basis, and they need education to do that, and a lot of them are willing to do that, but they have to know you can do that. So there's some, I'm one of my pet peeves is certificate of need, okay?
I was waiting
and
for it.
Everybody believes that certificate of need somewhat locks us into this ancient system, okay? And I think most people believe it needs to be changed. There's probably in the legislature 138 ways that we think it should be changed, but everybody knows it needs some change. To me, the change is to incorporate technology for a better work-life balance for our new students entering the environment, they can work, and for our older generation who might want to come in and can learn, like we're talking to older learners, and contribute, but not 100% of the time. So I think there's some things in technology that we're going to see for the rural healthcare, from distributing pods with technology, wellness, things that we're going to have to address on a regulatory basis and on a CON basis to be able to embrace fully the new generation of healthcare workers.
And we'll see a CON bill from you. And has that already been pre-filed, or are you working on it?
There is one that is out there. There's no pre-filing of bills, but I assure you there is a bill request in.
Okay, well, I'll look for it. Anyone want to comment?
I do, Renee, and it's related to information technology that Representative Moser and Senator Williams have both talked about. I believe confession is good for the soul. I was CEO of a small rural hospital, 75-bed in central Kentucky, and was one of the earliest proponents of electronic medical record. I think we did our first one in 2005, and I'm going to admit the biggest mistake I ever made. Let me see why. it was followed by the mandate from the Affordable Care Act that everybody had to have electronic medical record. The problem was there wasn't a good system out there, and most healthcare providers were not prepared for it. So we had to train employees in this particular area, and suddenly even the smallest hospital had to have a huge staff of information technology people, which is certainly good for that industry. But the problem is, while we're doing that, and while we're doing the Affordable Care Act, patient encounters increased by 20, 30%. But unfortunately, productivity for healthcare providers decreased 25, 30%. So we really didn't gain anything. But we have put in massive amount of dollars for information technology that I don't believe we're generating a sufficient return on investment on. And the problem is this was a government mandate, and this needs to be a warning for everybody, in particular to Senator Williams' point about we need new technology, is don't force it if it's not tested. And if it's a government mandate, you need to be concerned, because I think things need to evolve while they think through the capitalist model, that if it has value, meaning that you're going to improve the quality of care, you're going to reduce costs, increase efficiencies, by all means, embrace it. But I haven't seen that from the electronic medical record yet. It hasn't provided the value that we anticipated it would, and we should have gone slower and let it evolve. Again, what I consider naturally. And it is a major stressor for physicians and nurses, and I'm not sure how we turn this thing back. But again, technology is a great thing, but if you become a slave to it, you haven't gained anything. So I think we need to get back to basics on many things that we do in medicine, and I'm not sure that a paper chart is really all that bad, to tell you the truth.
This question, is it hard to find faculty because universities cannot pay as much as hospitals? How do we increase funding to universities to provide high-quality programs?
Everybody's looking at me. That is a challenge. Like I mentioned earlier, it's difficult to find people to teach in these positions because many times they would be taking a cut in salary. I think, and I'm going to challenge our universities who have these programs, I think we have to think more efficiently in all of our education providers. I know that Kentucky State University here in Frankfort, we got a question there. They've had to make some difficult decisions, and we passed legislation to allow them to do that. And maybe we need to look at that at some of the other universities. I recently talked to a university professor who has a program, I won't mention, it has no students in it, but he still has a tenured professor that he has to keep on staff. So I think we have to enable universities to give them the tools that they need. We have to think creatively in this. I think Senator Williams made a good point. The silver-haired people still have a lot to offer, and maybe not full-time, but maybe a part-time position. Somebody still wants to contribute, and they've got a lifetime of experience that's going untapped out there. So we have to think creatively. Funding is difficult. I've already seen the funding requests from higher ed this time. I did share that with Chairman Petrie. He didn't laugh, President Thompson. He doesn't laugh anyway. But anyway, we've got a lot of needs in the state, and you know, we're dealing with a teacher shortage in this state. That's kind of the base. If we don't have teachers in our school systems teaching our children, how are they going to be able to grow up and go in and have the skills and the knowledge to grow into professions like this? So we're going to have to think creatively. We're going to have to think outside the box. I wish I had a silver bullet answer, but I don't to that question. It's just something we're going to have to continue to work on and focus on. And the main thing is we have to communicate and work together collectively. And that includes the private sector as well. The private sector is involved in this, and we have to work together along with our public entities.
May I answer this first question? If you don't mind?
This one right here, and I think everyone can see it.
Kentucky is one of the most unhealthy
yeah.
states, and corresponding taxing on the health system is obvious. How can we try to address the population health legislatively? We can. Again, I'll remind you that 1.7 million of our population is on Medicaid. We've had managed care for over a decade now. In theory, managed care is supposed to improve the health of our population. We have not moved the needle whatsoever. Maybe, I think, from 49th to 47th, but I think that's because maybe more people have health care coverage now, but we have not improved the health of the population, and it is a problem. When I came to Senate in 2017, our Medicaid budget was $10 billion, and we were serving 1.3 million recipients. I said at that time, it's the largest it ever should be. I assure you, there's enough money in the healthcare delivery system to take care of man, woman, child in this country if we spend it the right way. And what we have to do is just reinvent this whole system of healthcare because we know it's not working. As I mentioned earlier, we spend double what other industrialized nations do, and our health outcomes are not as good as other nations. Personally, it goes into the structure of it. Personally, I would like to move away from managed care organizations. I think there's some other models out there. I think we need to push it back to the local levels. And, who do we want to be responsible for health care in America? I think it should be health care providers. But if you're willing to take on that, you also have to take on the risks associated with it. One of the biggest challenges we have is social determinants of health. We all know that 60-70% of the problems of health care are related to social determinants of health. Why aren't we addressing that? Well, folks say we don't have any money. We do have money, specific Medicaid program, $15 billion. So if we redirect those funds, really go back to basics again and build a strong primary care network with a focus on local health care, I think we can improve the health population. The savings that we realize from that can truly not only improve the health population, but reduce health care cost. And we've gotten away from that. Again, the worst health care outcomes are in rural Kentucky and our urban deserts we talked about because the funding's not there. So let's shift that funding, and we'll have significant savings from it. But I don't think the managed care organization is going to work. What I would like to really see is maybe a Medicaid block grant, similar to what Tennessee has done, and let communities truly be responsible for their own health care. I'll give you one example. My home county is Grayson County. We spend about $55 million in Medicaid funds a year, that community. And we've tried for years to have a smoke-free Kentucky, and it never has gone anywhere. And why? Because it's a mandate from Frankfurt and/or Washington. But if we put that money in the hands of the local leaders, and it's got to be a cross-section of leaders, county officials, school superintendents, police, interested citizens, to be responsible for those funds and tell them, you have to improve the health of your population. Whatever savings you realize from that, you get to keep. And you can use for infrastructure or you can use for education. Well, I assure you, I think there's at least a 10% savings there, maybe a 20%. But a county like mine to say, you can have $5 million a year or $10 million a year to do whatever you want to for your community, suddenly we focus on these issues like smoking. I guarantee you in my community, we said, you're going to get $5 to $10 million if you improve the health of your community. We'd be a smoke-free community tomorrow. Now, we've taken some measures to do that's been very slowly, but that's what we have to focus on, and just laser-like attention to these type of issues, and it's got to be local. One of the good things, there is any good things that came out of COVID, is the emergence of our county health departments. They were kind of forgotten for years, and they really performed like champions during COVID, and they showed that they can improve and help maintain the health of their population. I think we need to give more responsibility for local health care outcomes to those folks, but you also have to get the funding. But it takes a great leap of faith. I assure you again, there's enough money out there to take care of everyone's needs if we just spend it the right way. So we reduce bureaucracy. We have to do tort reform, which has already been mentioned here. It's critical. I remind you, most recently, Graves Gilbert Clinic, if any folks from the Warren County area, had a $21 million lawsuit that they lost. And what happened to the patient was truly tragic. It was horrendous. But it caused Graves Gilbert to file bankruptcy, one of the largest healthcare provider networks in South Central Kentucky. Well, long term, that's not going to impact Graves Gilbert or the people that work there because they will survive. But that's pushed on down to the healthcare consumer, increasing the cost of healthcare again. And I'm sorry, regardless of what happened to this patient and what happened to her was truly horrendous, $21 million is not going to reverse the course of action for that gal. It's truly more emotion than anything else. So if we had reasonable caps on jury awards, I think we reduce the cost of healthcare, and that helps with physician recruitment as well. But we have to reinvent this system. We truly do. We can't keep doing the same things we've done for years and years and expect different outcomes.
I want to go to this latest question. It's the bottom from Dr. Joy Coles, Kentucky State University. Any efforts to expand KEYS dollars to offer full scholarships for Kentucky students who pursue critical shortage areas like nursing if they plan to stay in Kentucky? Full scholarships.
Yeah, I will try to answer that, but I think the answer is going to be we would have to shift our focus from providing partial scholarships to all students who are eligible to a certain category, and I don't know that there's enough money in our KEYS system unless everyone out here just goes and buys a lottery ticket. But I mean, I'm not opposed to focusing on those critical shortage areas. I don't know if KEYS money is the way to handle that, or if it's through another loan forgiveness program or the P3 scholarship program that we passed last year. I think we've got a lot of things going on that are focusing on healthcare specific workforce. So maybe we look to bolster some of that. Whoops. I was going to make a comment, thank you, on Senator Meredith's points about our Medicaid system, population health. I think that, and I agree with Senator Meredith about the number of MCOs. I think that it is time to do a revamp of that system, but really looking at data and analyzing data that we have coming in. We don't have a central repository for that data. We don't have a great system of analysis, and that data is it's parceled out in such a way. I don't think that there's a great way to really look at how we inform policy decisions, and I mean, we could use data to look at how we fund scholarships. I think there are some programs that we can look at that I've come upon. I am looking at Leslie because we know that we have a mental health shortage in Kentucky, mental health treatment and healthcare worker. And so we're looking to expand a program that is actually underway with the University of Kentucky in partnership with UC Irvine to bring a psychiatry fellowship to Kentucky for primary care docs. And this is a one-year program that would better help train our primary care docs in mental health treatment, because they are really the first line of defense. So I think that there are some systems that we can bring in. I think there are system changes that we can make through better data collection and analysis. And back to the Medicaid issue, if we spend our money on the front end in prevention, we're always going to have a better return on investment and really deal with the high utilizers of the emergency department and the more expensive systems of care. So what I've tried to focus on in some of the legislation that I've passed with the community health workers and lung cancer screening, for example, is to really target those areas where we know we have a high lung cancer rate. We know that everyone has access to health care now through Medicaid, but they're not using it for whatever reason. So that was the impetus to really work on the community health workers. So there are things that we are doing that are targeting our Medicaid dollars to programs that we know work. And if we can get back to really preventative care as opposed to the more expensive ICU care, I think we're all going to win.
Well, I think we might have time for one more question here. I like this latest question. What about second chance employment initiatives in healthcare?
I think it's critical. We have to look at all avenues and all possibilities. You know what? We all make mistakes in life. And I'm a firm believer in grace. Somebody pays their price for their penalty. I think that is a part of our workforce that we have to tap into, because getting these people gainfully employed is going to reduce recidivism. And that's our ultimate goal, is for these people to be productive citizens. So I think that's certainly an avenue that we need to work on and provide those opportunities.
Conditionally, I would assume, certain
Sure,
nonviolent
under certain
felons
conditions,
under
yes.
certain conditions. That wasn't part of the crime package that some of your fellow House Republicans presented a couple of weeks ago. Perhaps you can attach an amendment there too.
Very possibly. We'll see.
Yes, Senator Williams.
I'd like to go back to a question that rolled off here about what are we doing to educate for teachers and healthcare workers, okay? I'm going to go back to technology. I just came back from a wireless conference where they were doing 5G telehealth from home, from rural conferences, and how this helps them. The other thing we've got going on in the state right now is we authorized at the school level virtual learning programs. We have one district that has
School-based
1,200.
healthcare centers.
Yeah, that. I asked a superintendent who has been a superintendent at in Covington, a superintendent in Cincinnati, how do we solve the teacher shortage? And he says, you're not going to solve it. That's not, you got to change the way you teach. And you've got to use technology, I believe, to both change the way we teach. We've got master teachers, and we need to, the good teachers, we need to leverage them. That was one of my church members. Another church member is getting a master's from Georgia Tech. I see her every weekend. I say, what are you going back and forth? She just says, no, it's all virtual. And there's a lot of things in medicine that can't be virtual. And we make the hospital or the university that is doing those clinical stuff part of that. But there's a lot that we can take excellent teachers and use this virtual technology to change. We have to change the paradigm. We just can't introduce into our existing paradigm. That's the phone that my parents would never have envisioned. And I think technology and telehealth is going to change both education and healthcare in the ways that we today can't envision. So
Senator,
we got to have the
don't
regulatory
forget
environment.
about AI.
Okay, I'll turn it off
I
now.
just came from a conference on AI in healthcare.
I'm excited to see if the General Assembly will address artificial intelligence next session. So a lot left unsaid, a lot of great questions that we didn't get a chance to explore, but thank you for sending those, and perhaps there'll be other opportunities for you all to discuss those. And thank you for being here this afternoon and for all the great work that you do. And I'll now turn the program back over to Dr. Sizemore.